robotic bilateral cortical sparing adrenalectomy with a paraganglioma excision, a rare 3-quadrant surgery. This is an interesting case of a 14-year-old boy who was found to have a very high blood pressure during a surgical evaluation of phimosis. On further evaluation, he was found to have bilateral large suprarenal masses, heterogeneously enhancing, and a small presacral mass. On biochemical evaluation, the norepinephrine levels were grossly high with normal other blood parameters. The diagnosis of bilateral active pheochromocytomas was confirmed on MIBG scan. He was started on alpha and beta blockade and planned for bilateral adrenal surgeries. In order to avoid the morbidity and a small risk of mortality associated with adrenal insufficiency, we planned for cortex preservation. Position was lateral decubitus. We used Da Vinci XI robot. For left side tumor, we used ports as shown in red. Same ports were used for the presacral paraganglioma excision as these two sides were diagonally opposite. For right side, new ports were inserted as shown in blue. Yellow ports were common, so the number of ports was reduced. Surgery started with splenic flexure drop and creating a space between posterior mesocolon and gyrotous fascia. Gyrotous fascia is excised to gain access to adrenal tumor and to isolate the main adrenal vein. Earlier clamping of adrenal vein is beneficial in order to avoid the episodes of hypertensive crisis. Main adrenal vein preservation is desirable but not mandatory and not always possible in most of the cases because of the close proximity of the tumor with vein, like here in our case. The tumor is manipulated with extreme care using blunt and sharp dissection, as excessive handling is known to cause intraoperative surge in blood pressures, which happened once in our case. The risk is usually reduced once main adrenal vein is secured. Gauze piece helps in dissection as well as in controlling small oozers. Fine and articulated robotic instruments give an extra advantages of precise and gentle dissection. This is the main adrenal vein being clipped. The tumor is then dissected all around, keeping a good margin from capsule. Exact thickness of margin in millimeters is debatable, but the most important thing is to avoid capsular rupture, which may lead to recurrence of tumor. Intraoperative ultrasound helps in differentiating tumor from normal adrenal tissue and should be used in such cases. We could not use it due to non-availability at our center. Other modality for demarcation is the use of ICG dye. Adrenal tumors concentrate more ICG and appear hyperfluorescent. Another challenge in adrenal sparing surgery is that the gland parenchyma is very friable. So gentle holding and dissection is extremely important to avoid the tissue trauma. Here I am separating the tumor from the remnant. It is imperative that the portion of gland to be preserved should not be mobilized at all so as to ensure an intact blood supply, and so peripherally located tumors are favorable for such adrenal preservation. Several studies have found that the remnant tissue volume as low as 10 to 15% is also sufficient to prevent hormonal deficiency. The specimen is bagged. The vascularity of remnant gland is confirmed using Firefly system with ICG. This picture was really satisfactory. Retargeting was done for presacral paraganglioma excision. A good CT understanding helped in exact location of this tumor. As this tumor was non-functional, its excision was comparatively easier. Robot was redocked for the third time for right adrenal tumor. The surgical steps and principles were almost similar as of left side. On right side, adrenal vein is short and its injury can cause significant trouble as it drains directly into the IVC. On right, we used vascular stapler as bleeding was more. The vascularity was again confirmed with ICG. Jackson-Pratt drain is kept. This is the post-op picture. Patient recovered smoothly and uneventfully. His blood pressure became normal from the day 1 without any medications. Histopathology revealed bilateral pheochromocytomas with no malignancy. Post-op cortisol levels and norepinephrines were within normal limits in post-operative period as well as in follow-up. So to summarize, surgery of functional adrenal tumors, especially cortex-sparing surgeries, are challenging in view of its highly vascular and friable gland tissue, non-anatomical cutting, possible risk of hypertensive crisis, and the stress of preserving functional parenchyma. Gentle tumor dissection and avoidance of capsular rupture is essential to avoid the risk of future recurrence. A multidisciplinary planning is very important for the successful outcomes. The advent of robotic surgery greatly facilitates this surgery, especially a multi-quadrant one. Cortical sparing should always be attempted whenever possible to avoid debilitating morbidity and a small risk of mortality associated with adrenal insufficiency. Thank you so much.